Hi, everyone. This is Dr. Janice Makela. This is Q&A with Dr. Makela. Welcome, everyone. I apologize. You hear the the barking dogs outside, or maybe you do. Um, I have a large 60-pound lap dog that thinks he's a tiny little dog and just barks really loudly. Also jumps on your lap anytime. Oh, and then a tiny little one that yaps a lot. Oh, I wonder things seem a little blurry. Let me get my glasses on. There we go. That's better. Reading glasses. So, anyway, how's everyone doing today? As usual, if you have comments or if you're here, if you're watching, throw your comments in, say hi, introduce yourself. Love meeting new people. There is a little bit of lag down LinkedIn. If you're watching on LinkedIn, it has a bad habit of delaying the feed for about a minute and a half sometimes. And so I might be already talking about something by the time you see it and put the comments in. So I will circle back if we need to. But I'm here for your questions. I address things. We talk a lot about cannabis, of course, because that's such a new thing that people have a ton of questions about it. But I also talk about geriatrics and hospice care. I'm the medical director of a small hospice. I'm board certified in geriatrics medicine and internal medicine and hospice and palliative care. I actually sat for the first boards for hospice and palliative care. It wasn't even a program until 2008. So in some ways, being at the forefront of cannabis medicine, endocannabinoid research medicine is not a new thing to me. Because when I started hospice, that was still kind of not, accepted. Heck, I've even had doctors call me a murderer to my face. Oh, let's straighten this up here a little. Oh, there we go. As I talk about serious things, and I'm adjusting my pin. But, well, it's true, though. When I first started hospice, a lot of people didn't know what it was. They assumed we killed grandma. Hey, Lance, nice to see you. So, yeah, when I started hospice, it was this idea that people at the end of life, that if you said, hey, you know what? There's no more options for cancer treatment, or I don't want to do this more advanced option. Yes, I could get the transplant for the heart, but I'm not a good candidate, or I don't want to deal with that. Or yes, I could get the this or that, but I don't want it, or I don't qualify for it, or I'm too frail. There's a greater chance I might die from, the aggressive treatments. Would rather live my life in comfort at the end of my life and be okay. And so that's where hospice came from. And it was actually a fairly new thing. There was a Dame Cicely Saunders brought it over from Europe. She created it in England, and it really didn't come to America until the 80s when it was approved. And at the time, doctors who did hospice were from other specialties. And a lot of times it was either the oncologist who saw people who had cancer and weren't getting better and needed some treatment at the end of life, or it was geriatric doctors like myself who saw people again at the end of life who said, you know what, I don't want all this stuff because I'm 85. And then there was a handful of ER doctors, ICU doctors, a couple other different specialties, a couple gynae doctors, gynae onc, again, cancer doctors, who said, we want to help these people. But it wasn't anything standardized. And so for the longest time, you would have people who just kind of did this as their part-time job. And so as a result, you would have hospice would be this sort of it was hodgepodge. Sometimes it was really good quality, sometimes it wasn't, and a lot of times it depended on the quality of the doctors. And it really wasn't until the early 2000s, and actually just outside in Chicago, on the north side, like in Glenview, Hospice of the North Shore, which doesn't exist anymore. They got bought up by another company, and I think they've been bought up by another one since. Um, was and Martha Twaddle actually started the idea of creating a fellowship and saying, no, we want quality doctors. So she paired with some of the local, I want to say it was Cook County and Rush, that she paired with to get credit to train her doctors in a fellowship program for palliative care. And that's why the American Academy of Hospice and Palliative Medicine is actually on the north side of Chicago, or actually the north suburbs, because that's where it started out from. And so up until that point, it wasn't really recognized as a medical specialty or a serious medical specialty. It was a side gig, kind of like cannabis doctors are viewed. It's like, oh, I just do something on the side, rubber stamp. There's doctors who rubber stamp cannabis cards, and then there's doctors who are like, tell me about your meds. Let's look for drug interactions. Let's see how it works. I want you to come back and tell me how you're doing, and you get that spectrum. And I see a lot of that from when I did hospice. And like I said, when I first did hospice, we were vilified. A lot of people thought we killed people. We don't. But a lot of people, I had an ICU doctor, and I get this a lot in hospice, right? People come to me and say, oh, I could never do what you do. And I'm like, oh, thank you. And they usually mean that as a compliment, like, oh, you work with dying people. Oh, I could never do what you do. He said, I could never do what you do because my religion prevents me from killing people. My jaw dropped. When I say my jaw dropped, I never heard anyone say that to my face, much less from a doctor, from a colleague. And he was an ICU doctor, and he would actually call us in the hospice whenever a family said, okay, the person's on a ventilator, they're not going to be coming off, let's withdrawal care. And he felt it was against his ethics to withdrawal care, so he would send them to us to do that. And and so he kind of, was it an insult or it wasn't nice though. He was like, no, I can never do what you do. That's why I send them to you. Because I can't kill people. I'm like, hmm. Now, fast forward 20 years of doing hospice. Almost any time now I tell someone I do hospice, they tell me, oh, that's so great. And then they proceed to tell me a story of a loved one that had a very peaceful and happy death well, as happy as death could be, right? Had a very peaceful death in hospice. So we see that, now that evolution of, much less of the hospice is killing grandma and much more of the, oh, we understand now what you do and the value you give to society and medicine and all this. And so it was a 20-year journey. It was the first boards were 2008. And even before then, like I said, it was in the 1980s that it first came to America. So it was a long journey to actually get hospice recognized as a specialty, and even a longer one once it was even recognized as a specialty, to have people actually see the value. Now, I think there's something to be said that cannabis is in some ways at a very similar stage. Right now, cannabis is not legal. the federal government, Trump keeps talking about wanting to reschedule it. He's made some comment. He posted something on True Social recently about CBD and elderly people, and he keeps kind of making some signals that he wants to legalize it for people who need it medically. Which I say, hey, you know, politics notwithstanding, you know, Republicans, Democrats, come together and do this. This is an important thing. But in some ways, we're also going to see medicine change. So we're seeing people go from, I've asked doctors. I just recently went on Facebook and I asked a group of a bunch of doctors, what do you think of cannabis as a medicine? And it was all over the board. I had some were like, oh, I use it for pain patients and it's great. Others were like, oh, I use it for this, and then there was like a little middle of the road one that was like, it can help, but I don't like dispensaries. I don't like the fact that we just send them and I'm like, yeah, I don't like that either, because you're trusting someone at the dispensary to tell you what dose to use and stuff. And they don't know your medical history. They don't know the drug interactions and the other meds you're taking. Now, some states do require pharmacists to be on staff, and I actually am in favor of that. My state doesn't, but there are things that would be good with that. Now, but then I had a lot of people who were like, oh no, it's a gateway drug. It became legal, and now I'm seeing a lot of cases of psychosis in the ER and addiction and this and that, and the drugs are increasing, and it's all bad. And then someone else says it causes heart attacks, and then someone else it causes this. There's a lot of pushback, and it's really hard to parse out in our society, right? The goods and the bads. But what I mean by that is cannabis does have some good things. And I'm going to get to that. There's actually a couple studies that just came out this last week I want to talk about. They're on my post. Please go read them on LinkedIn or Facebook now. But if you if you see those, great. But it's showing that there's more and more research and more concern that we need to be treating this like a medication. But again, a lot of people are kind of caught in this propaganda because it's been illegal so long. And we've had the whole war on drugs back when I was younger, right? And we've seen the opioid epidemic, and no one wants another opioid epidemic, though. Again, opioids, people can die from overdoses, and you can't die from an overdose of cannabis. So it's not quite a fair comparison, but I can understand where people are saying we don't want things to get out of hand. We don't want people, more people getting sick. People who shouldn't be taking it, take it, and then have those people get sick. I have to respect that opinion. At the same time, there are people who need it, just like opioids. Opioids kill a lot of people. There's a lot of people who have died from the opioid epidemic. But at the same time, does that mean we take it away from people who need it for cancer? No, I don't think so. Right? We don't take away medicines from people who need them. We try to be careful to make sure that only the people who need them get them. Now, yes, cannabis has a whole history of people using it recreationally. People who use it for its euphoric effects. Oh, thank you. Oh, yeah, I'll get to that. That's a good question. So, but I'll just finish up what I was saying and I'll get to your question here. So, we see that. We see people who have we see that in people who are using it recreationally. And I think we need to approach that differently. First of all, I don't think it should be illegal. We have tobacco legal, we have alcohol legal. Cannabis should be viewed the same way. And then if someone is using cannabis in a not safe way, a way that's not helping them, if they're getting harms from the way they use it, we should talk to them as doctors and say, hey, we need to talk about how you're using it because it's not helping you, it's only hurting you. And yes, we need to do research. The question about can it cause heart disease? Sure, we need to do that research because then that kind of gauges how we view it recreationally. Just like tobacco, just like alcohol. Arguably, is it safer than alcohol? Yeah, probably. But there's other issues too, right? You have driving, like driving with cannabis is not safer, right? So there are things that the recreational, but then there are the medical. Just because people are using it recreational doesn't mean you should take it from people who need it medically. And there is more and more data that people need it medically, that it serves a medical purpose, and that it should not be treated like an illegal drug. And so as that gets changed, I'm hoping that we will see medicine change too. And yes, you might get the advent, just like we had the advent of the hospice doctor, a board certified specialist in hospice. We might actually get the advent of the endocannabinologist, someone who specializes in drugs that cannabis can help, and also possibly specializes in the endocannabinoid system itself, which is independent of cannabis. If cannabis never existed, we still have an endocannabinoid system. And the most common thing that affects it are the fatty acids that we eat, followed by other things like, Tylenol is the most common medication that affects it. But now we found hydrochlorothiazide. As I said, there's the endocannabis system, and then there's cannabis. And there might be a future where the knowledge of this becomes a specialty in of itself. Or we train doctors and say, this isn't enough material at this point to be its own specialty, but every doctor needs to know this. And that's where we're going to get into one of the JAMA articles, because that's what they just said. Every doctor needs to know these 6 things. And they want it taught in medical schools. So let me just get to this question here, because this is Q&A. So the question was, thank you. What type of symptoms do older adults in hospice seem to get the most relief for when using medical cannabis? Well, I think the number one thing we hear about is pain. There are a lot of people who get sort of chronic pain. Now, the data is not very strong for cancer pain, oddly enough. And I think that's because cancer pain is really a combination of a couple types of pain. Because as a palliative doctor who specializes a lot in pain, though I'm not a chronic pain doctor, those are slightly different doctors. They do more interventional stuff. Dr. Newton, if you see him online, he's a chronic pain anesthesia-based doctor. Where they do more procedures, whereas I tend to give opioids and pain medicines to people at the end of life, but still have a very good knowledge of pain. Anyway, pain has different aspects. There's inflammation, like you twist your ankle or you have some arthritis and it's swollen and it's red and it's hot. That's created by one thing. That's created by inflammatory factors. Then there's sharp pain. I burn my finger, I cut my finger, the surgeon's knife, that type of sharp, ow, I pricked my finger on a needle. That is a different nerve pathway than inflammatory pain. There's also visceral pain, which is a type of inflammatory pain that happens in the bowels. No one unlike my fingertip where I can say, ow, I burned my finger. No one says, wow, my ascending colon hurts. No one can localize that well. And that's because we don't have those sharp pain receptors in our viscera. We just have the C fibers that are kind of vague, generalized pain fibers that kind of just go, ooh, ouch. And they respond to inflammation, like inflammatory pain. And then there's emotional pain. So, emotional pain, our brain processes the pain, and how we react to that pain affects things. So, if we're already in a bad emotional state, our pain is going to be worse. In fact, the neurotransmitters of depression and pain overlap a little bit. So, people prone to depression might be more prone to pain or experience it more acutely. Now, people who or just that people who have a lot of stress in their brain, a lot of existential dread at the end of life, whatnot, are feel pain more acutely because the emotional processing of pain, the suffering is greater. So we'd call that suffering. So acute, inflammatory. Then there's chronic pain where people are like, ow, it's like this, it's actually a dysfunctional pain. It's pain that doesn't go away after a while because most pain heals up. Most things that cause pain. Now the thing that injured you is gone, but it still hurts. That's chronic pain. And we found that the pain transmitters are messed up in chronic pain. Then there's neuropathic pain. So that's a nerve that's damaged. So all the little nerves, like you hear of neuropathy, the nerves that do with your sensation, that gets affected. So a reason I explained all that is because sharp acute pain that, ow, I burned myself, does not respond well to cannabis. It does respond well to opioids. That's why cannabis will never fully replace opioids because we're going to need a role for that. But like a lot of times a cancer is actually like eroding into something, is actually breaking through the skin. It's doing something that causes sharp pain. And cannabis is not going to fix that. So, but there is a lot of evidence about chronic pain. And that's the second study, actually, for chronic low back pain that it can help. Now, that's not going to be my hospice patients. But there's also evidence for neuropathic pain. So, when someone has nerve problems, that it can help. And inflammatory pain because of its effect on the immune system to kind of modulate it down a little bit. It might decrease inflammation. And so by decreasing inflammation, it decreases that inflammatory pain. Perhaps not as strong as the steroids that I would give someone, but it certainly can help. But where I think it helps a lot is the suffering, because a little bit of that disassociation, a little bit of that, I just feel kind of better, that mood effect, that euphoria. You know, they always talk about cannabis creates euphoria. I think that euphoria kind of helps the emotional aspect. So people who do have a lot of anxiety, a lot of end of life existential dread, suffer less with cannabis. So you hear a lot about that. People use less opioids. They use less, medicine for anxiety. And those are the chronic. We have a little thing called the comfort pack. It's like 5, 6 different meds that we give everyone. So if you have an emergency at 2 a.m, we can give you can take, and morphine's part of it, Ativan's part of it, Haldol in case you're getting hallucinations, or it also helps with nausea. So does cannabis, right? So morphine, Haldol, Ativan, Tylenol in case you have a fever, a Tylenol suppository, and what else? Oh, and often they will give you actually an anti-nausea medicine in the pack too. And then something to dry the mouth in case you have secretions at the end of life. A lot of times people can't swallow their saliva that they make at the end of life, and they get this gurgling sound. And it's really distressing to the family. Not so much to the person who's going through it, but the family hears it and goes, oh. And I think it's because it's in our DNA. It's like fingernails scratching on a chalkboard. That sound, that end of life, just grates on people because we know it's the sound of death. And so that's where I think at the end of life, we see cannabis really helping is I think it helps a lot with the emotional aspect of it. And then I do think there's a lot of evidence that it synergizes with opioids. So you get stories of people who needed less opioids, who used cannabis, and their family was happy because they were more awake because the opioids made them sleep or the opioids made them constipated. And with the cannabis, they were able to be a little bit more engaged with their family. And that makes sense to me because we know that the inhibitory pain pathway, the pathway that opioids work on to block pain, actually works to that pathway actually works with the opioid pathway at the spinal level, but in the brain level, it's actually the CB1 receptor, the cannabis receptor, that stimulates that pathway. So those two points in that same pain blocking pathway, one is opioids, one is cannabis. It makes sense that they work together to be a little bit stronger. So perhaps maybe you do need opioids, but maybe not as much. Maybe not as much that you're asleep all the time, not as much that you're constipated all the time, and not as much as you're delirious. So yeah, that's where I see it. And as a hospice doctor, that's actually where I saw it the most. Now, cautionary tales. As a geriatrician, I had someone whose family ran out, and I tell the story all the time because it's important. I had someone whose family said, we went to get grandma some gummies because we heard it might help her behaviors in her dementia. And there's some studies to say it might, but they couldn't remember the dose. They just grabbed some gummies. They asked the guy, and he probably gave them the dose that those 40-year-olds, 30-year-olds that were doing this, buying it, would have needed, not the dose a 90-year-old would have needed. The poor lady slept a day and a half, and her family never touched it again on her. Did she have a good night's sleep? Sure. Was family worried? Yeah. Did they ever give it to her again? No. So this is where, did she have any ill effects? No, because you can't overdose on cannabis. But what you see in these situations is people need some guidance. So this actually segues into one of the new articles that just came out. And this is huge news. I'm going to actually open it up on my phone so I can pull up the same things on it. But it was published in the Journal of the American Medical Association, so JAMA, one of the biggest medical journals out there. And JAMA Open, they've expanded a little bit, so they have their open access line. But it has an article that basically is still the fact that it's in anything JAMA. They brought in experts from around the country and asked them what needs to be taught about medical cannabis. And right? Yeah, again, we got a little delay here. I was saying, she said she'd rather take cannabis than haloperidol. We don't need antipsychotics at the end of life. Right? Well, that's it. I mean, Haldol can be very useful in very specific circumstances at the end of life. Low dose can help with nausea, but again, so can cannabis. And low dose can also help with even higher dose with hallucinations at the end of life. So you get stories about people who get hallucinations. They get very agitated. They don't know whether their brain is starting to die, the oxygen's starting to go off, and they don't know what's going on. And they just start screaming and getting really sort of, ugh. And so that Haldol can help calm that down. And I think that's where a good role for it is. But you're absolutely right. A lot of times what they end up doing is they give the Haldol for sundowning, or for something that's just like the advanced dementia, the sundowning, or other things that are just a little agitation, where maybe the cannabis could help, you know, and a person might feel a little bit better with the cannabis where they're not as aware, because Haldol has side effects. We see that. Haldol is not Haldol can we don't worry about the heart side effects, the irregular heart rhythms that can happen with Haldol, in at the end of life. But I have seen situations where some people overly aggressively used it, and so I had a patient with dementia, and they called me in, and she was literally doing this, rocking to try to get up from her seat, but she was a little too weak to stand. But she was just rocking nonstop. And the nurse was like, "Why is she doing this?" And I looked at her meds, and she was on Risperdal and Haldol and stuff for her behaviors. And I said, "Okay, let's try to take away the Haldol." Not only did her behaviors kind of improve, but that rocking stopped, because that was akathisia, which is this weird uh, motion disorder where you have to keep moving, or you just feel compelled to move, and it's caused by the Haldol. So, yeah, Haldol's not great. Haldol does have its role, and that's what I say about every medicine. Every medicine has side effects. Every medicine has benefits. There are people, I'm glad Haldol exists for the people who need it. Do I think it gets overused sometimes and used in the wrong people? Yes. This is why we need to continually educate people on when and where not to use it, and why I think it's important we have other drugs like cannabis that can help with that. Mhm. Now, let me talk about this one study. So, JAMA, Journal of American Medical Association, just came out yesterday. And they said, quote from the study, "The use of medical cannabis continues to expand rapidly across the U.S., yet most healthcare practitioners and trainees report feeling unprepared to counsel patients or integrate cannabis into care." That is, even if someone had come up to the doctor and said, "I'd like to use it for grandma," or "I'd like to use it myself for XYZ," most doctors wouldn't know what to say, or whether it was appropriate, or wouldn't know how to monitor, or of, "Hey, I think you're using it the wrong way or for the wrong reasons." So doctors don't know that. So they came up with 6 competencies. And if you don't know, in like the education world, we talk about competencies, which are things that we expect someone to know by the time the training is over. And so, number 1, understand the basics of the endocannabinoid system. Preach, right? This is what I have been saying. You need to understand this. We don't teach this. And the endocannabinoid system goes beyond cannabis. Preach. Understand that. Describe the main components of the cannabis plant and their biologic effects. Yeah. You need to know CBD, THC, the plant, the flower. I mean, I've practiced so many years thinking that people smoked the leaf instead of the flower. And then, what's funny? I put a post on that on LinkedIn and had about 5 other doctors confess the same thing. They're like, "Wait, they smoke the flower?" This is not known if you don't do cannabis. Everyone sees the leaf and assumes this. So, yes, learning the main components, understanding how it works, understanding THC and the different presentations. Review the legal and regulatory landscape of cannabis in the US. Yeah, I mean, it changes so much, right? And then describe the evidence base for health conditions that are commonly managed with cannabis. We're going to talk about one of those that just came out last week. Um, and say, because even some of the reviews are suggesting that for chronic pain, for certain conditions, for MS, even some of the most staunch anti-cannabis people are like, "Well, yeah, okay, MS, sure." You know, understand the potential risk of medical cannabis use. That's something we don't always hear in the cannabis world is the risks. In fact, you start mentioning some of the risks and people get really upset, partially because you have the other extreme where you have your people who are against it who grab onto that and say it's happening everywhere. And then you have other people who are like, no, it never happens. Like, no, the truth is probably somewhere in the middle. Again, some people are going to react one way, some people are going to react another. Right? Let's see. I'm not surprised. Peter Grisman is right. Cannabis does help, and the endocannabinoid system should be taught in medical school. Right? Exactly. And he is 100% right. And then actually, if you look at this article, there's a number of who's in the cannabis world who are part of this. I'm a little late to the game, so I wasn't in this one. But there are a number of people, the names you guys might recognize. So understand the potential risk of medical cannabis use. Understand the basic clinical management with medical cannabis. Now, they originally had this broken down into a couple different things, but it's this basic idea of what's a good starting dose, how to manage it, when should you increase it, when should you tell someone that now maybe you need to take a break, maybe you're getting too much tolerance, and how to pull back on it, right? And get people used to sort of lower doses. And I know there's this, personally, I find a very interesting nursing school as well, right? Maureen, hi. Yes, nursing school as well. I agree. Actually, kudos to the nurses. They have a much more organized group. And I think it's because nursing is much more into well, I'm not exactly sure. I just know docs are often very paranoid about it and are a little less accepting for the more. And so I've seen a lot more of acceptance of cannabis and a lot more education from nurses about cannabis. So kudos to them on that. So I agree. Nursing school too. Understand basic clinical management. So again, how to prescribe it, how to give it, how to monitor it, that's what we should be doing. And to all of these competencies, I say, amen. We need to do this because we all just bury our heads in the sand and we all just hide ourselves and we're like, I did not prescribe it. Because we tell doctors, oh, you're not actually prescribing it. You're just saying that they certify for the medical card. And that way we get around the idea that the doctor's prescribing something that's technically illegal and they could lose their medical license over. Because if I was to prescribe someone, heroin, I can't because it's Schedule 1. But if I said, yeah, go and take some heroin, I would go to jail if I did that regularly. If I wrote everyone scripts for morphine and said, yeah, morphine for you, I would go to jail. So doctors, when they started coming out with these legal cannabis programs in the state, were very scared of, I could lose my DEA license because the DEA says it's illegal. And even if I don't go to jail, they may take away my DEA. In fact, that's part of the reason I never entered this space until recently, because I live and die by my DEA, because all those comfort meds I talked about earlier, about half of them require a DEA to get so that my patients can get comfort at the end of life. If I don't have a DEA, I can't practice hospice. So the DEA is super important. And so I think that kind of hangs over a lot of doctors, that we could potentially lose our license, and particularly our DEA license. And so a lot of doctors don't want to talk about it. And so the state said, okay, listen, you don't have to prescribe it. You just have to write a card that says they have a condition that qualifies them to get it. And that mindset has created this block where doctors are like, okay, I just signed the medical card. It's like writing for a handicap placard. I don't have to park the car for them, right? Analogy falls apart a little there, but I don't have to park the car for them, but I write the thing that says they can park in a handicap spot. The same way, I write that they can get cannabis. You know, I write, I write that they're eligible for disability, And so these types of things, they put it on a level of that, which means I don't have to think of it beyond that. Oh, they qualify. Oh, they're using cannabis for their MS. Okay. We have to break doctors out of that mentality to say, I don't have to think past writing the card. It's, okay, you're taking cannabis for your MS. How is that going for you? How are you doing? Are you having side effects? Is it helping your MS? Is it treating you? What dose are you taking? How are you taking it? Are you smoking it? Are you doing gummies? Are you doing tinctures? What's working for you? Are you aware that if you use an oil tincture, that there might be, if you swallow it, that might affect its absorption compared to an alcohol tincture? There's all these different things that we have to talk about, and that's what doctors need to learn. So that's why I'm here. That's why I have a program to teach doctors about it. That's why I'm here to tell you. And if you know a doctor, if you are a doctor and you're like, oh my God, I need to know more about this, reach out. I have a program, a 4-week program where I train doctors on what they need to know as a primary care doctor to treat their patients who use cannabis. So that's that with that. And I'm like, yay, JAMA finally caught up. So yes. And so that was the first article. The second article that's come out recently is, this came out last week, and someone just shared it with me yesterday, but it's huge, huge. Because people always say to me, there's not enough evidence. How can you support something without again, it's evidence-based medicine. We only do stuff if there's research to show it works. But research costs money. Research costs money. And so if you're just a small cannabis company or a small university or a small person, and you don't have an NIH grant because it's federally illegal, so where are you getting that money from? And so it's hard to do big studies. Now, in Europe, where it's a little bit more legal, there was a German company, and they have some venture group that owns them. And they actually have gotten to a phase 3 clinical trial. Now, you may not know what that is. Phase 1 trial is just like, is it safe? You take kind of healthy volunteers and you just kind of check them. Did you feel sick? How are you doing? No, phase 2 is, did it help a little bit? Did it make you feel better? Did it make you, it's kind of an intro one, right? And then phase 3 is the real big one. These are larger studies. Phase 2 is a much smaller population just to kind of test the waters. Phase 3 is a huge study. And in this case, it was like 840 patients, I want to say, that they looked at. And they showed that, and as a randomized controlled trial, that's another term that everyone wants to see. What that means is that it's randomized. So who goes into group AV is random. You're not just watching who kind of self-selected. Okay, who wants to be in group A with the cannabis? Who wants to be in group B without the cannabis? No, it's blinded, which means you don't know what group you're in. Controlled, so there's a control group. So randomized controlled trial. So randomly put into different groups, blinded to which group you're in. Controlled, meaning one of the groups isn't getting the intervention and the other one is. And you compare the two groups to make sure that in all other ways they're very similar. So randomized controlled trial. Now, it was published in Nature Medicine. So just like JAMA, a Journal of American Medical Association, is a huge group in America is a huge journal in America. Nature is a huge journal out of Europe, very old, very prestigious. It's gone back many years. And when you're published there, you have to be really high quality to get a published article there. Now, can you go back and say, yeah, this was disproven, or yeah, this was, yeah, sure. I mean, they've been around forever. There's been some bogus studies that end up there, but for the most part, they hold really high standards to what they publish. So if you're in Nature, it's a really good sign that you're a quality study. So this is a randomized controlled study done in a large population of patients. Phase 3, which is the final phase before someone would apply for drug approval. So these people are very much trying to get European approval with this study. And the minute they can do it in the States, they're going to try to get FDA approval with this type of study. And it's published in an S tier, one of the major medical journals. So it is about as good as you can get. When the people say there's no good studies, this is a good study. And it showed they took a proprietary full spectrum extract tincture from their plant. So they bred their own strain. They have the patent on their strain. People say you can't patent a plant. Well, you can patent the DNA on a plant. And so that's what a lot of companies are doing. Betocam in the Netherlands doing it. Charlotte's Web does it. These guys are doing it. That seems to be a trend, that people will make their own strain, and then they will patent the DNA on their strain, and then use the tincture from that strain and get the approval and say, we used a tincture from this strain of plant. And that is how they're kind of getting around the fact that you can't patent, cannabis as a whole. Anyway, so what they did with this is they compared it in people with back pain. Remember I was talking about chronic pain and how chronic pain's really messed up, and there's in its signaling, and there's actually some studies that cannabis might help fix that. So there was some studies that showed that a proprietary full spectrum extract helped chronic low back pain when compared to placebo. So placebo group A, cannabis group B, they gave them each, and the cannabis group had less pain. They did better. They had less pain. They were just generally happier. And when they took it off, the cannabis group felt it more. They're like, oh no, we have our pain, but so it was definitely an effective treatment. And now, was it compared to opioids? I actually hear that they're in the process of doing one where one of the arms is opioids. But when you read the medical literature, what should you not use for back pain? Opioids. Cochrane, all of the major medical journals say for chronic low back pain, opioids do not have a role. There's a little bit of a talk that tramadol might be kind of okay-ish. And part of this is because chronic back pain does hurt for people. And even though the guidelines say no opioids, there are people who do it. And it is back pain and the use of opioids, though, that really sort of funded our ongoing problems with the newer opioid epidemic, where, if you may remember, the OxyContin folks, and they paid a lot of money to all the different states to settle on this. OxyContin came in and told every single doctor, oh, we have this new opioid. It is less addictive and not even really that addictive. It's less addictive than morphine. It's great for back pain. You can give it to them and they'll feel better. And all these people got addicted to it. And then all these people dying from overdoses. Now, can people get addicted to cannabis? probably. And we should watch for that, right? But the good news is people aren't going to die from overdose with cannabis because you can't. It doesn't affect you like a. So I would say, it's safer. It's safer than the opioids. So they actually said, cannabis can be an alternate for people with chronic low back pain as and now the question I have on my post to every doctor out there, is this enough research for you? Is this quality enough? Is a study that shows it helps pain, lower back pain, that's published in Nature with hundreds of patients in a phase 3 clinical trial, is this study good enough? Or do we have to still keep proving to you that cannabis should be a medicine? What do we have to do? We already have, as medicine, synthetics THC, dronabinol. This was made many, many years ago because cannabis was illegal. So they synthetically made it in a lab and said, well, this isn't made from the cannabis plant, so it's legal. And so they made it for nausea and for HIV anorexia. But no one says, oh, but the cannabis plant, they say, oh, but there's no evidence for it. I'm like, the THC is the same between those. And then all the European studies with sativix. And they're like, oh, well, the studies aren't big enough. They're not large enough. They're not. Phase 3 clinical trial, 400 and some patients, or no, it was more than that. Phase 3 clinical trial of full spectrum published in Nature showing that it helped pain. And we'll still probably get haters. But that is, and oh, they looked at side effects, by the way. People are going to say, oh, but the side effects. So here, let me get it up. So they looked at, here, abstract. They said there wasn't very many side effects. The European studies are written with the order a little bit reversed here. Between the statistics and the methods are often put backwards. So give me just a second. Oh, tolerability and safety. Here we go. 85% of the population compared to, okay. So there was some treatment emergent adverse events, 83 of the population compared to 67 in the placebo. So that was a difference. But they showed that serious adverse events, so really, bad outcomes, were comparable between the two, which meant there wasn't really any. The most common, dizziness, headache, nasopharyngitis, fatigue, nausea, COVID-19. What? Dry mouth and somnolence. Rates of headache, nasopharyngitis, and COVID-19 were similar between the groups okay, so that makes sense. COVID was the same. Whereas dizziness, fatigue, nausea, dry mouth, and somnolence were more frequent with the treatment group. Not surprising. Notice we're not talking about a lot of, euphoria or dysphoria in that. Most of them were mild to moderate in intensity. The incident of drug-related decreased over the course of treatment, so people tended to get more used to it, converging towards weekly incidents below 3%. So there was some more people who stopped it, and we see that with most drugs. 17% stopped it because of side effects, compared to 3.5% in the placebo. most commonly due to dizziness, somnolence, and nausea. And so no deaths occurred in the study. No clinically important treatment-related changes were observed in the clinical parameters. So no one's labs went wacky. No one had strange findings. The EKG and the vital signs stayed steady. So no one had a hypertension. No one had a heart attack. No one had, new arrhythmias. And 68% were satisfied with the tolerability of treatment compared to 79 in the placebo. Satisfaction with tolerability further increased during the open label long-term treatment, reaching 83% at the phase B and 84. They divided it into some different phases. So that's to say that no AEs indicated of drug abuse, dependence, or withdrawal as classified under respective were reported. So they actually did monitor them for addiction. They monitored them for dependence and tolerance and withdrawal. And they did not, under their standard procedure of monitoring them and stuff, didn't see any signs of abuse. Furthermore, there were no signs of drugs abuse based on urine tests or addiction behavior checklists. So guess what? It wasn't a gateway drug. Right? They didn't suddenly start using cocaine. In fact, we know in other studies, people are less likely to use other drugs. No participant fulfilled the classification criteria for substance dependence according to the 10th International Classification of Disease, so according to the ICD-10. No withdrawal symptoms after abrupt treatment discontinuation in phase D. So basically, people did well, and really, if you call nausea and headaches and dysphoria like the worst things you get, have you watched a commercial for a drug company and then listened to the side effects? Now, listen, as a doctor, I'll be the first to say, you're not going to get all of those side effects, right? I always argue with people who are like, oh, but I heard it does this. I'm like, yes, that's a very small number of people. You really need this drug. Otherwise, you're going to get sicker, So, I caution that they have to say this and you have to take it with a little grain of salt. But just to say that if cannabis had that do at the end, it would be shorter and it would have less severe side effects listed. Just saying. So, anyway, that's two big things in the cannabis world that just hit. And let your doctors know. They need to know about this. Spread the word. Spread the word that there is medicine, that there are studies now. Spread the word that they need to know about this. Their patients are using it. But what's more is it is clearly a medicine. They need to know how to use it. Again, that's why I'm here. I have a course if anyone wants to reach out to me. If you have a doctor that you're like, and you talk to them about cannabis and they look at you a little bit like, and you say, well, yeah, I need it. And you say, doctor, would it interact with my drug, this, that, or should I take, how should I do this? And they go, give them my card. Give them my number. Open up the LinkedIn and say, hey, reach out to Dr. Makela. She can help you. So, yes, it is 7:59 here. I know there's a little bit of lag. I'll just see if anyone has any more questions or anything they want to throw in before we go on. But yeah, an eventful week here. I hope everyone has a great day and a great night. And thank you, everyone, for joining us here. Thank you for the lively comments and for joining. And I hope everyone has a great week and you stay well. I hope to see everyone next week. Let me know, in the week, is this useful to you. I do this on Thursdays, and I do it because I want people to learn about this stuff. And Sometimes I can go off in a little ramble or whatnot, but I want to just, I think it's important that this information is out here in an unbiased way. Yeah. Yes, cannabis is an exit drug. Oh man, I think we really are quite delayed on LinkedIn. I should tell people that they should probably try to use YouTube next week because the LinkedIn has such a terrible delay that I'm already like a couple minutes in, and the yes, cannabis is an exit drug. So, oh yeah, I can see where we're at here on the LinkedIn Live. It is really behind. Okay.
What you see in these situations
Whoops, hang on.
is factors about it.
Whoops.
That's why I'm here.
There we go. Yes, we are really behind on that. That's crazy. Anyway, you were the first person in Canada to be prescribed Sativex. And like dronabinol, it did not work for me as neither is whole plant medicine. You have to have all the cannabinoids if you're treating most health conditions. Yeah, there's increased evidence about that. And we are definitely going to be seeing that in the near future. Europe is going to be posed for that because this new company is not the people who make Sativex. They're a German company. It's like Vertanical or something like that. And so this is VER1 is what they're calling it right now before they can come up with some fancy name for it. And they are primed to be the competitors to Sativex. So we will see whether Sativex gets washed being an isolate with just CBD and THC versus a whole plant with the full extract. That would be an interesting head-to-head study. I don't know if we'll see it. We often in medicine don't see those types of studies because when drug A that does something goes against drug B, you risk that you could lose. And so a lot of people don't want to spend that money. In fact, very famously, of a very big cholesterol study that actually showed this is why doctors now say, oh, we want the LDL as low as physically possible. That was done because we were originally thought it was below 100. And I'll just go on for a second. No, we're over time. But below 100 LDL was all we needed to get. So new drug on the market. They were not as strong as some of the stronger statins. But they said, that's okay. We don't have to be. We just got to get people below 100. So they took people and they said, okay, we got a bunch of people we put below 100. And we went head to head against a bunch of people in our competitor's drug who took an equivalent dose. Except for their competitor's drug was stronger and it got them below like closer to 70, right? Whereas they were just 99. And so because of that, they've said, well, as long as it's under 100, our patients are going to do better, right? Because that was the prevailing thought. Those people who were closer to 70 on their competitor drug did better. So they completely shot themselves in the foot. Plus, they showed that no, LDL should be lower than, not just lower than 100, but for diabetics and certain people, closer to 70, or even lower, well, lower, okay, really low, you get into some trouble, but, but that's not the point. The point was just that, so we may never see Sativex versus VER1, but that would be the interesting study to see if a isolate drug versus full spectrum works better. I tend to agree with you, Allison. I do think that there's growing evidence that full spectrum has more potency and more interaction and possibly even more tolerability than the isolate drug. So let's see. Okay, well, time is wrapped up. I'm going to wrap up here. Again, great talking to everyone. Thank you all for being part of today's conversation. I hope you all have a great week. We'll see you next week and take care.